Thank you, esteemed chair, ladies and gentlemen. A new outlook on hypertensive retinopathy. No relevant financial disclosures. So, hypertensive retinopathy is known to progress through distinct stages, more or less. The vasoconstrictive, sclerotic, and exudative phases are associated with no complications. But then, when the complications ensue, they include retinal edema, subretinal fluid accumulation, and neovascularization. However, neovascularization currently is not included in the spectrum of hypertensive retinopathy. Although initially it was described in 1987, it was later included in a review article in 2016, and subsequently it became known that any neovascularization must be considered a part of hypertensive retinopathy after thorough evaluation excludes other causes of proliferative retinopathy. Still, this neovascularization is not included in any grading or classification system for hypertensive retinopathy. Venous hypertension is the result of ischemia and microvascular occlusions, which may or may not coexist with clinically obvious retinal vascular occlusions. Arterial sclerosis in hypertensive retinopathy is basically mid-peripheral, and so occult peripheral arteriolar occlusion or tributary venous occlusion of the retina must be considered whenever neovascularization is encountered, even without obvious retinal vascular occlusions. Various pathophysiologic, clinical, and epidemiological studies have been done, which confirms the role of hypertension being in close relationship with retinal vascular occlusions, to the extent that about half of all RVOs are attributable to uncontrolled hypertension. RVOs also subject the affected eyes to additional interventions like laser photocoagulation, anti-VEGF agents, and the risk of complications related to these procedures or progression of the neovascularization. NVG and tractional detachment are the dreaded sight-threatening complications. Literature has demonstrated some of the cases which have neovascularization in the setting of hypertension, in which hypertension alone has been attributed as the cause of the neovascularization. Brancato et al. Reported the first case in 1987 in the case of toxemia of pregnancy, wherein DIC was the incrementing factor. However, accelerated hypertension induced fibrinoid necrosis and consequent occlusion of peripheral retinal arterioles appeared to be the major pathophysiologic factor in that case. Georgiadis showed macular ischemia, peripheral retinal ischemia, and neovascularization with vascular leakage in a case of extended occlusive vasculopathy of unknown cause, which was later revealed to be malignant hypertension. Abbasi et al. Showed a case of severe hypertension with systemic complications. Golshali and Avila reported a case of hypertension secondary to IgA nephropathy, wherein the diagnosis of massive retinal and choroidal infarction was made with NVG and TRD. Stryjewski demonstrated a case of vitreous hemorrhage, FVP, TRD, and neovascularization. Speed has shown a case of bilateral neovascularization and vitreous hemorrhage. Although the patient had vasculitic risk factors, the authors concluded that retinal findings were attributable to hypertension alone. This case also landed up with extrafoveal tractional membranes. Jung and Ameri also showed CNP and neovascularization, and the left eye had clinically obvious neovascularization, angiographically diagnosed to be due to superior nasal BRVO. This case showed that the FFA alone may reveal an RVO even if it is not clinical obvious. And this case also shows that multiple interventions may be required in patients with RVO and NV in hypertensive retinopathy. Based on all the literature, Mishra and et al. Have recently concluded that current classification systems do not provide adequate coverage to malignant hypertensive changes. They demonstrated a fundus picture of one of their patients with superotemporal BRVO along with possible cilioretinal artery occlusions with inferior subretinal fibrinous exudation due to associated choroidopathy. In our experience, we did a survey of 40 cases in which 10 eyes of 9 patients presented with retinal vascular occlusions. The high rate of retinal vascular occlusion is consistent with other studies. And it is not necessary that this is associated with hypertensive crisis alone. Stage 1 hypertension and stage 2 also showed retinal vascular occlusions. This is one demonstrative case which presented with old bilateral STBRVO and NVD and NVE, which were subjected to anti-VEGF injections and photocoagulation. The significance and clinical application of this discussion is that whenever we encountered these kinds of eyes, we must consider that these eyes already have ischemic and long-term damage by occult, if not obvious, vascular occlusions. The RVOs may not be so obvious, so we might consider FFA, especially wide field FFA if available. In our experience, hard exudates and macular starts are not demonstrated with FFAs, but non-perfusion leakage, microaneurysms, and shunt vessels are well demonstrated. So the new outlook now includes addressing the chronic global ischemia associated with hypertensive retinopathy, considering the risk of neovascular proliferation even without clinically obvious RVOs. The new outlook now also includes to differentiate the retinal vascular occlusions found in a background of hypertensive retinopathy changes from the RVOs occurring in the absence of hypertensive retinopathy changes. And we might even make an overarching claim of proposing a new classification system of hypertensive retinopathy, including retinal vascular occlusions in a background of hypertensive fundus. Thank you.